This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, and welcome to the Neurology podcast. I'm Jessica Ailani, Director of the Georgetown Headache Center at MedStar Georgetown University Hospital in Washington, D.C. In this session, we will be discussing the article, Long-Term Epidural Patching Outcomes and Predictors of Benefit in Patients with Suspected CSF Leak Non-Conforming to ICHD-3 Criteria by Ian Carroll and colleagues from Stanford University in California. Intracranial hypotension is a syndrome that causes a constellation of neurological symptoms, including headache, neck pain, nausea, and vertigo. It's also a syndrome we've been learning a great deal about over the last few decades. As a headache specialist, I have to say that SIH frightens me in a way that anything that's hard to diagnose does. In clinical practice, I often find that the textbook patient with SIH can be very satisfying to diagnose and treat. But it's the refractory headache patient who has limited migraine symptoms and more predominant fatigue and vertigo, and possibly has that positional headache and has normal imaging findings that makes me really anxious. What do I do for this patient? Do I offer them a blood patch? Do I do some fancier imaging? Do I go and cry a little bit in my office and phone a friend? I'll tell you that's generally what I do. So before we discuss your study, what is the International Headache Classification Disorder criteria for SIH?
So that ICHD-3 criteria you're asking about was designed and is essentially a radiologic diagnostic criteria that's augmented by opening pressure. So basically, the criteria is there should be a headache that prompts looking for a CSF leak or leads to its discovery. But really, the meat of the criteria is in Part B, where the ICHD-3 says that you have to have either or both of a low opening pressure or a positive imaging study. And what that really means when you get down to it is that they've codified it as a radiologic rather than clinical diagnosis that they've then augmented with a low opening pressure. And so they've put that forward, and that is what the current diagnostic criteria are.
So most of the subjects in your study did not meet these ICHD-3 criteria for SIH, but you proceeded by giving them an epidural blood patch. So tell us, why did your team start doing epidural blood patches for these patients initially, and what led you to actually perform this study?
Clinically, I had become interested in CSF leaks in part after reading a very nice review article on SIH done by Wouter Schievenk that he published in JAMA in 2006. And it just spoke to me. And so I wound up pulling the references and reading those and becoming more interested in CSF leaks. And over time, taking notes on what things had really been learned about this condition. And as I was practicing in my practice, I was seeing patients with headache who had many features of CSF leak. They often reported an orthostatic headache. They had in their history things like, I remember one patient had a history of atraumatic subdural hematomas, elevated CSF protein, elevated prolactin, things that indicated it was not a primary headache disorder. But when we imaged that patient and others like her, we were seeing that their imaging was almost always read as negative or normal. And some of them had such good stories, like the one I just mentioned, really you wound up saying to yourself, maybe the sensitivity of the imaging isn't quite what we think it is. And so this patient, and we know that nothing's 100% sensitive, and so we offered some of those patients epidural patching. And I should say, we often did it after reviewing their images with the neuroradiology team, where we would say, listen, I realize that you don't see a leak here, but tell me, if you were going to patch this person who has such an outstanding story for a CSF leak, where would you patch them? And they would say all kinds of interesting things, like, I don't see a big leak here, but there is this very prominent bone spur at T4-5 poking into the ventral dura, and that's where I would patch if I were you. And so we would do that. And some got better and some didn't. And at some point, there started to be some controversy. Should you be patching somebody whose imaging is negative, especially when that patch requires a significant amount of technical expertise? Doing an epidural blood patch in the neck or in the thoracic spine, it's not something that a lot of people feel extraordinarily comfortable with. And the question becomes, at what point is that appropriate or not appropriate? And we had discussions about that within our institution and decided, listen, the important thing here is that you start tracking outcomes so that you learn who this works for. Does it work? When does it not work? Who should you not do this for? And that we're not fooling ourselves as we go along. And that's ultimately what led to the study.
What you're describing is that beautiful flow of clinical practice right into a scientific experiment. So a really nice story of trying to make patients feel better and realizing tracking outcomes was important to ensure you understood the right patients to do this in. And it is intriguing, just like yourself, sometimes we'll see it with the neuroradiologist and what is read as normal all of a sudden is, well, it's not 100% normal. There is this and there's that, and I could do this and I could do that. And it always does make you wonder, all those normal reports, are they?
Yes.
Is everything really normal?
There's no substitute for going and sitting and talking with a neuroradiologist and going over the scans and asking a different question. And it really did flow from trying to help patients. And then once we started seeing some patients really benefiting, realizing as I was talking to people in this field that patching these patients who are imaging negative or whose opening pressure is not low was really quite controversial and wasn't being offered uniformly across medical centers. And so it represents something that data really can speak to and start to provide evidence to either support or direct when this should and shouldn't happen.
So tell us a little more about your actual study design. And I want you to talk a little bit about your embedded controls. So how many patches were done per patient, how they were their own types of control, how you really designed this study.
So what we did is we started asking patients that we were treating in our normal clinical practice, we started asking them to complete a set of validated metrics online before undergoing their first epidural patch. And then we asked them to complete it again after any subsequent patch that they received. And the goal was simply to track outcomes. And so we chose some general outcomes and some symptom-specific outcomes. So for general outcomes, we chose a metric called a PROMIS quality of life global health metric that has a physical subscale and a mental subscale. The PROMIS metrics were developed essentially through a consortium supported by the NIH because they were tired of having one group of researchers use an SF-36 and another group of researchers use a different quality of life metric. And so they started to essentially convene scientists to come up with metrics that they thought could really supplant these legacy metrics that would have favorable statistical properties that would make them easy to understand and have good test-retest reliability. And then to promote them, they started, and I'm not sure if they're still doing this, but they started giving people who are writing NIH grants a little bump in their score if their primary endpoint was going to be using one of these PROMIS metrics. And so we started using them and decided to use the PROMIS global health metric as our quality of life metric. And that was going to be our primary way of deciding whether this was really helping people, is to measure their quality of life through this PROMIS global health physical and mental subscores. And then we had a bunch of symptom-specific metrics that we wanted to capture too, to see what was getting better, what wasn't. And so we used the Headache Impact Test 6, the HIT6, to measure head pain. We used a Neck Disability Index to measure neck pain, a Dizziness Handicap Inventory, and then a PROMIS metric of neurocognitive concerns and a PROMIS fatigue metric. And so we really wanted to capture the core metrics of symptoms that characterize CSF leaks and spontaneous intracranial hypotension.
So primary endpoint was really quality of life. And then secondary, looking at all these metrics that were related to what people with CSF leaks were coming into, which you described really well in your paper. These nonspecific headache, neck pain, vertigo, vestibular ocular type symptoms, and fatigue, which we do see commonly with people who have frequent headache. I have to say, I really like a primary endpoint focused on quality of life metrics. I think this is really important, and especially clinically, anyone taking care of those with headache disorders understands that when we focus on headache days, that doesn't really translate well to being able to function. But quality of life measures really translates well to functionality in the patient. And I think that when we look at studies, very easy to translate to patients when you're talking to them. These things are improved over time. Much easier to say that on average, you might have 5 headache days less per month. That really doesn't resonate to people. I don't know if you find that to be true or not when you're talking to people.
I think having a global health quality of life metric is absolutely critical because you really want to get them better in a way that's meaningful to them. And it also allows you to put it in perspective with regard to both what's normal and other conditions that other doctors can understand. So by using a PROMIS global health metric, when we see that their physical score at baseline is 32, these PROMIS metrics are designed so that the US norm is 50, and 10 points is a standard deviation. So when your score is 32, which was the average score among the 85 patients that we patched, whether they were imaging positive or not, so of the 85, the average score was 32. There are 2 standard deviations below the mean, the US population mean, in terms of global physical health. They are in the 4th percentile. They have levels of global physical health that are similar to people dying with HIV, people with advanced lung cancer. These are people who are profoundly impaired. And so I think that's an important part of the study too. I wasn't patching people who complained of headache that were really doing okay. These were people who were just profoundly affected and for which trying something was medically appropriate.
Yeah, no, I think that really speaks to understanding the type of person that you're seeing in front of you and why a procedure is really the next right step. So tell us a little bit more about your findings. You mentioned there were 80-something patients. How many of these were radiologically negative? On average, how many patches were delivered per patient? And on average, how did they do? What did you find?
All right. So first, before we image them, we see them in clinic. These 85 patients, 84% of them are complaining of orthostatic headache. 99% of them are complaining of headache, but 84% are orthostatic. And when we talk to them, their mean duration of symptoms is 8.7 years. These are people who have been suffering and having impaired quality of life for a long time. They've had lots of treatments, they're highly refractory, and their quality of life is terrible. And when we imaged them, what we found was that 16 had either a low opening pressure less than 6 or positive imaging confirming and meeting the ICHD3 criteria. The other 69 were ICHD3 negative. They didn't have a confirmatory imaging study. They didn't have low opening pressure. And we stratify our analysis in the paper by whether they were in fact ICHD3 positive or ICHD3 negative. But what that really means is whether they had a confirmatory test, imaging or opening pressure or not. And what we found was that, not surprisingly, maybe it is surprising because they had symptoms for 8.7 years. We found that in the 16 patients who were ICHD3 positive, despite having symptoms for 8.7 years, we saw a clinically meaningful response in PROMIS Global Health in something like 88% of those patients. But what was more surprising was that in those patients who did not have a confirming test to meet ICHD3 criteria, 54% had clinically meaningful improvement in PROMIS Global Health when measured 521 days after the first of an average of 3.6 patches. So we didn't just patch them once and say that's it. They said that they were somewhat better. We would give them another patch. And so in the cohort as a whole, they received an average of 3.6 patches. Each patch had as an average 2.5 levels that were patched. So they might have had a needle at L3-4 and another one at T9-10. So an average of 2.5 needles per patch, 2.5 sites per patch, an average of 3.6 patches among the cohorts. But when you looked at them, an average of 521 days after their first patch and over a year after their last patch, in general, we had statistically significant improvements in PROMIS global physical health, PROMIS global mental health, the HIT-6 score, the neck disability index, and also PROMIS fatigue. So improvements, mean improvements across all of those things that were statistically significant. And again, not just statistically significant, but 54% of those ICHD3 negative patients, those without a confirming study, had clinically meaningful improvements, meeting previous published thresholds for what kind of improvement in global physical health was clinically meaningful. And because most patients were actually imaging negative, even though the rate of response was lower, it was 54% instead of 88%, because so many more people were negative, when we looked at the people who had actually had a clinically meaningful improvement in the whole cohort, for every one patient that had a clinically meaningful improvement after epidural patching who met criteria and would have been designated for patching if patching was predicated on having a positive imaging study or a low opening pressure, for every one patient like that who had a clinically meaningful improvement, there were 3 others who would have been excluded if we had followed ICHD3 criteria, who actually had clinically meaningful improvements that wouldn't have gotten that patch and wouldn't have gotten that improvement if we had predicated our patches on ICHD3 criteria. And that, I think, is the message to get out there. Now, the countervailing argument, maybe we shouldn't be patching these people who are ICHD3 negative because maybe it causes more harm than benefit. When we go and we look at our data and we say, listen, we're going to not just look at who had clinically meaningful benefit, but we're going to look at who improved by a full standard deviation, a full US population standard deviation in quality of life compared to those who decreased by the same amount. The ratio of people who improved a full standard deviation in quality of life to those who got worse by the same amount favored treatment by 13-1. There were 13 times as many people who improved a full standard deviation among the ICHD3 criteria negative group, the ones with imaging negative, compared to those who worsened by the same amount. And so what we really don't see is evidence of harm.
And what we would call that for a drug is number needed to treat versus number needed to harm.
That's right.
Really great analysis there. And 13-1, number needed to treat to harm, is a fantastic number.
Yeah, it's saying, look, patching isn't perfect. There are people who get worse. But the percent and the number of people and the ratio of improvement to harm strongly favors giving these patients like this, who are really impaired to start, a trial of this epidural patching. Now, I should say, when we look to see post hoc whether we were able to predict who among the imaging negative patients were more likely to benefit, we found that there were 2 things that we could measure before patching that wound up strongly predicting who was going to have a clinically meaningful improvement in global physical health over a year after their last patch. And that was just how low their head pain got when they stayed flat, either for an hour, that was one predictive variable, or how low their head pain got after staying flat all night. For every 1 point drop on a 10-point scale, so if you measure head pain 0 to 10, for every 1 point drop on that scale for head pain after being flat an hour, there was a 39% increase in the odds of being a clinically meaningful responder. In other words, this specific dimension of orthostatic headache, not how bad is your head pain when you're up, not how long does it take for your head pain to be bad when you're up, not how long does it take for you to feel better when you're flat. How low does your head pain get when you're flat is strongly predictive of, are you going to be a responder to epidural patching when you are imaging negative and you don't have a low opening pressure. And that's hard to explain with a placebo effect. And that's hard to explain with regression to the mean. It strongly implies a causal relationship.
I just want to reemphasize the fact that the effects of the blood patches, 3, lasting with these kind of effects lasting greater than a year, 514 days, right? That's what you said. This is way past a placebo effect. We often see when we patch patients, even those that clearly meet ICHD3 criteria, but the area is wrong or they move too much after, whatever it is, these things wear off pretty quickly if they don't work properly.
You're absolutely right. For many people who have a leak, the patch isn't as durable as you want it to be. What's interesting and what I think we are capturing is even after that initial period where the leak is tamponaded and they feel great, if their leak symptoms come back, this data suggests they're not coming back all the way. There is persistent benefit, and that persistent benefit is clinically meaningful. It's not as good as we want it. These people aren't fixed, but it's important and it's better.
I think the improvement is important to understand as someone who is seeing these patients often is the sense that nothing has improved them. Anything that causes improvement also adds to the level of hope in their life when they have been literally not functioning, as a patient told me today, in the basement, fully dependent on a parent as an adult, completely at wit's end at the end of the line.
Not only that, as you treat these patients, quality of life that you're measuring in them doesn't really fully capture it. If you're a mom or you're a father and your quality of life is 2 standard deviations below the mean, that is cascading into the generation behind you. Your kids are not getting what they need from, and I don't want to stigmatize it, but when we're impaired, when we're sick and we can't take care of ourselves and we can't be upright, the quality of life improvements that we're generating when someone gets better, it applies to them and it applies to other people too. We just don't measure that and include it in our studies.
Ian, I wanted to get back to something you were discussing with being able to ask the questions about patients to predetermine who's going to do well. Tell me a little bit about how you ask this clinically to the patient about their headaches when they're laying flat. Because I sometimes struggle when asking a patient, do your headaches improve when you're laying down? Are you better sitting up, laying down? Do you get better through the day? Sometimes you ask this in a series of ways and it doesn't quite come out right. Any advice about how to really ask the patients this question about improvement when laying down in such a way that we're really getting to this orthostatic component properly?
I think there's 2 dimensions to that question. There's what we did in the study and what we do as we're seeing people in clinic. In the study, we were asking people different dimensions about the orthostatic headache, like what's your head pain after being flat for an hour? What's your head pain after being flat for a whole night of sleeping? And that was being deployed through an online questionnaire. But in the clinic, the counterpoint to that is we have a structured CSF leak review of systems where we go through this and we ask them some of the straightforward questions like, do you feel better after being flat for 30 minutes? Do you feel worse after being upright for 30 minutes? But actually, a lot of what comes out that can be useful are the questions that recognize and integrate that for many people with a chronic leak, they don't feel better right away when they're flat. It takes longer. And sometimes if they have a slow leak, they don't feel terrible right away when they get up. It takes longer. And questions like, how do you feel? How does your head feel in the morning when you wake up before you get up to go to the bathroom? So that person has typically been flat for 8 hours or some number of hours. And that may be the best that they are. They have now not had the hydrostatic gradient of being vertical applied to their leak site for 8 hours. Their symptoms may be at its best in that moment. Now, there are circadian effects too, and it can be hard to tease apart, is this really circadian or do they just feel better because it's the morning? But if what they say is, my head feels pretty good when I first wake up before I get up, but 20 minutes later, after I've been up and started walking around, I'm starting to have some issues. Or if they say, yeah, I'm pretty good for the first 3 or 4 hours of the day, and then as the day goes on, things just become a mess. It is reliably worse later in the day. So a lot of these patients will say things like, I plan all of my activities for the first 3 hours in the morning because I know I can't do anything later in the day. Because remember, these patients, they're not just having terrible quality of life. When we looked at their PROMIS fatigue scores, they were in the top 5 percentile for the nation. These scores reflect US population norms. When you're 2 standard deviations above the mean for fatigue, you are in the top 5th percentile for fatigue, according to the US. That's what these patients were and are sometimes living with. And they are just really impaired. They may organize their whole life around being able to get some work done in those first few hours when they first get up. And then when you get a hint that actually they have a terrible headache every afternoon, but they're okay in the morning, you can start to ask the question, in a way that hasn't yet been validated by research, you can start to ask the question, is this circadian or is this postural? By simply telling them, listen, on Saturday, you are going to stay flat all day, and we're going to see if you get your normal afternoon headache at 2 p.m. the way you always do, because you have then divorced activity and circadian rhythm from posture.
I really like this. I already have a list of patients these questions are going to be deployed to in my mind. It's really important. And I think you're so accurate in the sense that there are many people with chronic headache types that will worsen as the day goes on because of rhythm patterns. And it is hard to tell. And especially someone who's had orthostatic headache for almost a decade, which is the norm. It takes a long time sometimes to reach these diagnoses. A lot of things start to fall away. So making the diagnosis becomes really hard.
The other aspect I would add to this is we know that the CSF communicates with the perilymph in the inner ear. And the presence of vestibular cochlear symptoms in these patients is really quite prominent. There is a high frequency of tinnitus. There is a high frequency of at least intermittent vertigo or dizziness. Some of them will describe, so you have the cochlear symptoms with the tinnitus. You have them often reporting that their hearing is altered, again, a cochlear symptom, and then the vestibular symptoms of dizziness, vertigo, and then many of them will have a tactile sensory disturbance that is also related to that change of perilymph pressure, a subjective sense that they just are trying to pop their ears all the time and it just doesn't quite work. And so they will have this constellation of vestibular cochlear symptoms telling you that there's something off about the pressure in the inner ear. And of course, it's easy to sometimes say, oh, I think that's part of a vestibular migraine complex, but it should raise a flag. An orthostatic headache in the setting of vestibular cochlear symptoms should really have you looking at this hard and asking, maybe I should push past this initially negative brain or spine MRI. We know now for certain that a major cause of spontaneous intracranial hypotension is an entity that was simply unknown to medical science before 2014. It's when the CSF leaks directly into a vein, what's called a CSF venous fistula. And of course, it's invisible on MRI because you do an MRI. There's no epidural fluid collection. The veins have fluid in them, but of course they have fluid in them, right? That's not unusual. But we now know from prospective series, now that we know how to look for this with special kinds of imaging, lateral decubitus digital subtraction myelography or lateral decubitus CT myelography, if you can get contrast right over where the CSF leaks into a vein, now we can visualize these. And now that we're doing that, we see that this is not 10% of leaks. This is like 50% of CSF leaks. And we also know that now, if you look for those kinds of CSF leaks, the CSF venous fistulas, in people like the ones we patched, orthostatic headache, MRI brain negative, MRI spine negative, that depending on which cohort you look at, between 10% and 15% of these people can be demonstrated, if you do this invasive lateral decubitus imaging, to have a specific CSF venous fistula that is treatable. And so the imaging is now catching up to what we were doing with the patching at the beginning, which is saying, look, maybe our previous reliance on imaging needs to be looked at with appropriate, not skepticism. Skepticism is not the right word. We need to understand that there are limits to the sensitivity and even limits to our ability to truly assess the sensitivity of, say, an MRI of the brain for spontaneous intracranial hypotension, because you need a gold standard to say this is when we're having false negatives. And we haven't had that. And so we've been triangulating to try and figure out exactly what is really the sensitivity of MRI of the spine or brain for CSF leaks. And we've just been having trouble nailing it down for a long time. So that's part of what is some of the critical thinking behind, look, maybe these patients with orthostatic headache who are really impaired deserve a trial of therapy.
So as we get to the end, I wanted to ask you, did you convince your institution to let you keep doing these patches in these patients after they saw your results?
Yes. When I started this, patients like this were never getting an opportunity to get better, and now we're sometimes seeing them quite a lot better. And those patients were being seen before patching in the headache clinic, in the pain clinic, in the autonomic neurology clinic, by the neurosurgery service sometimes. And many different services have seen patients that were, in fact, chronically quite ill and debilitated coming back and with clear, visible improvements in their quality of life and function. And so over time, the results create the belief.
Thank you for sharing that. If you want to learn more about Dr. Carroll's study, long-term epidural patching outcomes and predictors of benefit in patients with suspected CSF leak, non-conforming to ICHD3 criteria, it's published in the Green Journal, either online or in print, so go ahead and check it out today. Thank you, Ian, again for joining me today, and thank you all for listening.
Thank you, Jessica. It was a pleasure.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.